All right.
All right, so welcome everyone to this next set of series of the Global Surgery webinar series. My name is Dr. Pablo Estrella. I'm the chair of the Junior Doctors Network, and it's a pleasure also to support our Global Surgery Working Group that has been doing a lot of work to bring this series together with the Incision team. So without further ado, I will hand over the floor to our co-chairs, Dr. Preeti and Dr. Ramita.
Hello, everyone. I'm Dr. Preeti. So today is the second episode of the Global Surgery webinar series, and we have Dr. Ramita, the co-chair, and Zadey, who will be engaging with us on this interesting topic. So over to you, Dr. Ramita.
Okay, thank you, Dr. Preeti. And hello, Incision team as well, Isa Shah and Abdul Karim and everyone else from Incision. It's very nice to see you. Without further ado, I will right now go to introduce our guest speaker for today, Dr. Siddesh Zadey. Dr. Zadey is the co-founding director of the Association for Socially Applicable Research, also known as ASAR, a pioneering think tank based in India. Uh, he is currently pursuing his doctoral studies in epidemiology at Columbia University, while also serving as a global surgery researcher with the Gemini Research Center at Duke University. He completed his academic training at the Indian Institute of Science Education and Research in Pune and at the Duke Global Health Institute in North Carolina. His work has spanned from health system modeling and population level health challenges, with a special focus on surgical care, to advancing access to gasless laparoscopy in low income countries. Dr. Zadey also brings a wealth of leadership experience. He is the acting chair of the Asia Working Group of the G4 Alliance, a fellow of the Lancet Citizens Commission for Reimagining India's Health System, and a member of the drafting committee for the Maharashtra State Mental Health Policy. His contributions extend globally as part of networks such as the Global Burden of Disease Collaborators, the Mental Health Innovation Network, and the Global Mental Health Action Network. His scholarship and thought leadership have been widely recognized, with publications in leading outlets including the Lancet, JAMA Surgery, Lancet Global Health, BMJ Global Health, the World Journal of Surgery, and Surgical Endoscopy, among others. Notably, he has been honored with the Consortium of Universities for Global Health's Dr. Judy Wasserheit Young Leader Award and was named to be the inaugural cohort of the 40 under 40 public health catalysts by the Boston Congress of Public Health. Please join me in welcoming Dr. Siddesh Zadey.
Yeah, thanks so much, Ramita. That was wow. Uh, yeah, that was like it's always kind of funny to uh hear your CV read back to you. But thanks so much. That was really nice. And I think we have very limited time. When I was preparing for this talk, I realized that there are two ways to do this. I could either take you through everything that I have been taught at whether it's ICER Pune or whether it's Duke Global Health Institute or whether it's now Columbia, uh, right? Uh, and kind of like really dive into like the theory of decolonizing and all of those things, right? Or B, I could try to sort of really surgically remove all the layers and tell you what honestly I have learned or have not learned and I'm still struggling with. And so I thought that given the length of time that we have today, and given the audience, which is mostly really young students, uh, I chose the second option. And so a lot of what we do today is going to be activity focused, interactive. It's going to be rather than me telling you things, it's going to be me just posing questions and you thinking through and answering some of those questions. Okay. Uh, Before we jump in, I would like to thank the Junior Doctors Network of the World Medical Association and Incision for inviting me for this. Uh, while preparing for this talk, I also sort of put like a crowdsourcing alert on my LinkedIn network saying that I'm doing this. Do people have ideas? And there were a lot of people who were enthusiastic about what this session should look like. So I would also like to thank all of them who sort of, yeah, really chimed into forming not just this talk, but also my articulation about a lot of these issues. Uh, yeah, I'm affiliated to a bunch of places. I also have some of the other roles that I thought would be just in the spirit of transparency, important to share with all of you. Uh, However, what I would like to do for a moment is now pause and just highlight some of those things there. And so here the idea was just to look at some of those words. And as someone who was born and raised in India, a lot of there's a lot of, if you see, there's a lot of colonialism going on in that slide itself, right? Uh, and so my sort of purpose today is for all of you to recognize how colonialism is not a construct of the past, but how it's a living, breathing entity among us, or even within us, and then sort of take that thinking and try to see if we can challenge that, if we can change that, and if we can improve on it and upon ourselves, right? Uh, so a lot of the groups, institutions that I have highlighted here have in the past participated in one way or another in colonial practices. I would argue that including the group that I helped co-found, which is ASR, uh, also has certain colonial lingerings in the methods that we use, in the way we interact with other people, uh, or just in terms of who we work with or who we work for, right? So this talk, I hope, is more about self-reflection than anything else. All right. So what we are going to do today is I'm going to try and talk a little bit about global surgery and how it developed as a movement versus how it has developed as a discipline. Uh, then we'll move on to talking a little bit about how at least I have been trained, or how at least I look at decolonizing in the context of health and medicine. And so that's kind of along two axes, questioning and doing. Uh, then across these, I'm going to talk a little bit about just 3 examples as case studies. And we are going to do an activity for all of you to see how you can employ a line of questioning to see how there is colonization all around us and what we should do about it. The QR code there is I think if you scan it on your phones or like iPads, laptops, whatever, should get you to the link of the poll. It will probably show that there is no active poll right now, but that should change in a minute when we start going through some of the questions. Uh, does this plan make sense? And it won't take too long. My plan is to wrap all of this up in like 20 minutes. So we'll have enough time, hopefully, for questions, discussion. I know that the moderators, so Preeti, Ramita, did an excellent job of putting together some very critical questions in the brochure or the document that was sent around. So I definitely want to get to those. All right. The QR code will keep popping up on the question slides as well. So if you are not, like, if you haven't scanned it right now, you will have other opportunities to do that. Okay. So we'll do one quick question as practice, but we'll have, yeah, we will sort of have uh, the exercise going ahead. Are you all able to see the code now? And is it working?
Yes.
Okay, awesome. And yeah, I mean, folks who are on this call can start responding. My guess is that it should show up on the screen ideally. I'm not sure if that's going to work out, but we'll see. So I'm going to do this with you as well. So okay, So it looks like it's not popping up on my screen here, which I'm sharing, but it should pop up on sort of like the poll screen that you're seeing on either your phone or whatever device you have joined to. So I can see people talking about equity, access to care, surgery for all, innovation. So great. So let's keep doing this for maybe like 20 more seconds, and then we can move on. Awesome. I also see UHC, so that's great. Cool. So we can let these populate, and I'm happy to share all of this with the moderators ahead, because I think I'll get like a nice AI summary thing out of this. So okay, cool. But let's move on and talk a little bit about global surgery as discipline and global surgery as movement, right? And so again, when I was preparing for this, one of my friends and colleagues in my LinkedIn network said that, why do we call it global surgery and not surgery, right? I mean, there is no global maternal health. There is just maternal health, or there is no global child care. There is just child care, or there is no global HIV. It's just HIV, malaria, tuberculosis, right? And so, what's the point of adding a global before surgery? What does it signify, right? And so this is the line of questioning that I think we should be thinking about and rethinking about as interest holders in the field of, I mean, narrowly medicine and surgery, but also broadly health and global health. So my take at this would be that surgery has a long history going back to centuries. Global surgery is more of, so let's talk about the discipline. So global surgery is more of a field that came up maybe in last 20 years or so. And so there are like antecedents to the field, but the way we know it today, it came up as a discipline maybe in last 20 years, where people realized that in order to, if the goal is that we need to make surgery accessible to everyone around the globe, it's not something that a bunch of surgeons can do who are already busy operating on people. So we are going to require a larger group or cohort of people to sort of use an umbrella and push for this as an agenda, right? And so global surgery currently is not just surgeons, although a large chunk of us are surgeons, but also other healthcare workers, nurses, epidemiologists, health economists, and a whole bunch of people who are using research, advocacy, clinical skills, and community engagement largely to ensure how we can truly get equitable access to surgery for everyone, right? So that's sort of like the discipline of global surgery as far as I can see right now. And I'll also put a caveat that it keeps evolving every day, right? So maybe 5 years ago, there were no health economists who were interested in it, but now we see health economists really interested in solving problems of healthcare insurance for surgical patients, right? Global surgery as movement can be, maybe I would argue, it can be like traced back to 2015 or like 2014 as the year. So that's the year when like Lancet Commission, the Disease Control Priorities Network, the WHO resolution, all the things came out, and kind of like surgery perhaps for like the first time came on everyone's agenda, especially on the policymaking and governmental agenda around the world, right? And so since then, a lot of focus within global surgery as a movement has been on how can we advocate for financing for surgical care of people who really need it and are deprived of it, uh, but also for pushing surgery across all sectors. So not just health, but also talking about what are the implications of treating people through surgery and for them to go back to work and lead a happy, healthy, normal life, right? That has economic impact, that has societal impact. So global surgery as a movement, I would argue, has largely been an advocacy movement for surgical patients and for pitching surgery as a solution to a whole bunch of problems from infectious diseases, non-communicable diseases, and also injuries, right? A lot of global health is centered around disease conditions. Global surgery is amazing in the way that it's centered around a solution, because we are not talking about what problems people face. We are talking about how we can really solve them using, using sort of like the traditional clinical solutions that we have and that we keep building. Let's also talk a little bit about what we mean by decolonization and what, at least I would argue, is the essence of how to do it. And so the reason I put this graphic was this from, I think, like a collection which was published in the British Medical Journal a couple years ago. But I think it's an important graphic to sort of like tell us that this is a map that probably all of us have seen since childhood. And yet it feels so different because we have always been shown it in a certain way. And so the way this map has been shown to students, professionals, and people around the world is in itself a colonial viewpoint of the world, right? It tries to put the countries that were part of colonial regimes, that were the colonizers in the north, and the ones who were colonized in the south. So how you look at the map, how you present the map is in itself a colonial construct, right? And we still do it. Like in any place, in any conference, in any seminar that you go to, this is not the map that you see. You see a map which is sort of switched around and where you see US, Europe at the top, and then the global south in the bottom, right? And so I think what that signifies is that when we are talking about decolonization, again, we can talk in a lot of depth about what that means to different people and how it should work out, whether decolonization is the right way to go about it, or should we be more radical. So one of the folks on LinkedIn asked me that I'm happy to provide suggestions, but how radical do you want to be in your talk, right? And that's a valid point. So a lot of my colleagues would argue that maybe decolonization is kind of a mild step. What we really need is anti-colonization, where we actively say that these are the things that we want to work on, take back, and own, right? However, for the purpose of this talk, I would argue that there are at least two ways in which we can do decolonization, right? So my definition of decolonization would be that it's basically changing your worldview and questioning everything around you that you can to ensure that it's not contaminated by the traditional history that we are taught, right? So the first piece of that would be questioning, and we'll go through that as an exercise. And the second piece of that is that questioning or critiquing or thinking is not enough. We also need to then do something about it in order to change things. And so instead of trying to explain more, my goal today was to take you through examples of how this might look like. Okay, so our framework would be that we are talking about global surgery as a movement, and we are talking about global surgery as a discipline. And then we are talking about decolonization as questioning and decolonization as doing. And so I'm going to try and talk a little bit about each kind of like an example or like a case study in each of these. And then we'll do the global surgery, questioning global surgery as a discipline from a decolonial lens as an activity. Okay. Cool. All right. So questioning the decoloniality of global surgery as a movement. Like I said, most people would argue that the movement started in kind of like mid or like early 2010s. And it has been a relatively strong movement with a whole bunch of organizations, people, groups, regions joining in. And so on the face of it, it might look like, oh wow, this is amazing. We have already achieved what would essentially look like decolonial, because you have all these people from different places joining in, saying their piece, and yeah, that's kind of what we want, right? However, once you start questioning who is joining the movement, who is being allowed to talk, who gets the stage the most, who is considered a pioneer or a leader in the movement, who gets the funding, who gets to, I mean, including like organize and talk in seminars and webinars like these. Once you start questioning that, you can clearly see that there's still a lot for us to do when it comes to decolonization, right? And so Professor Dhananjay Sharma, who is now a retired veteran surgeon from Jabalpur, India, which is a relatively small town. He worked there as the head of surgery for, I think, about 2 decades, and before that as a consulting surgeon for another 2 decades. So, Professor Sharma and I thought that we should talk about this, and we should talk about this in the context that we know, which is India. And so in India, what we see is that, of course, India has been independent since 1947. But once you start probing that from a decolonial lens, you will realize that there are still a lot of things that restrict the freedom of a lot of different people in India, including in progressive circles like public health and global health, or even medicine, right? And so we thought talking about that and sort of like framing it a certain way in which people would get it would be important. And so we talked about the idea of local elite capture, right? And how that perpetuates new colonization, so new forms of colonization within the Indian context. And so I kind of want to just like read out the highlighted part here. So our idea was that we see that in a lot of places, local elites, so these are people who look like me, who talk like me, but are positioned at the top of the food chain, often engage in gatekeeping of resources, of training, of opportunities. They prevent the trickle down of resources and opportunities from the global north that are intended to benefit all institutions and individuals, right? And I'm pretty damn sure that this is not exclusive to India, and that this happens in almost every country in the global south in one way or another. In the context of India, we also highlighted how and where it might happen. So we then start seeing social and gender-based disparities. We see disparities due to the caste problems that we have in our country. We see the class disparities, and we see that members of dominant cultural groups tend to emerge as local elites in any field, including medicine and public health, right? And so it becomes really important that as we participate in global surgery as a movement, we also kind of turn the lens on ourselves and ask ourselves, who is this movement about and who is allowed to be part of this movement, right? And so sort of like this article was a way of talking a little bit about that. But I think, and there are tons of good articles doing the same thing. There are also amazing people, young people, and students also sort of pushing the envelope on this line of questioning. So I would encourage all of you to, yeah, maybe just sometime today or this week when you have time, try to see if you can find things on decolonizing global surgery and how different people talk and think about it. Okay, the next thing that we want to do, and I think this is like a good also pause for me to stop talking. And I thought what would be good is then my guess is that you kind of like get where I'm going with the line of questioning. And so what I want all of you to do now is apply that, and let's try to probe how global surgery as a discipline looks like from a decolonial lens, right? So if we were to flip, if we want to flip that picture of how the global map typically looks like, I think it's really important to start questioning some of these things of, yeah, what global surgery itself looks like. So let's see. Okay, is this working? Can you see the question in the poll on your devices, which is also on the screen? I think I would just need like maybe one thumbs up. Okay, awesome, cool. So the question is, who is one person or like research group, institution, organization that comes to your mind when you think of the word global surgery? If there are people here who don't know much about global surgery, you can also answer this as a question about global health or about medicine, and that's fine. And so maybe we'll give people about like 15 seconds to put in responses. And I would urge everyone to be open and like honest in this exercise and not sort of like try to think of responses that might look better or that might be better. Yeah, just things that would genuinely come to your mind. Okay, cool. So I see, oh wow, I see like Lancet Commission, PGSSC. Awesome, this is awesome. All right, we'll give maybe like 5 more seconds and then we'll move on to the next question. And I want you to hold on to your response. Yeah, like remember what you said. Wow, I also see incision, so that's great. Because the questions are connected, so you'll see how that goes. All right, should we move on? This is amazing. I also see Surge Hub. I see Dr. Lakhu, who's amazing, by the way. Yeah, I have known her for several years now. Okay, cool. Let's keep going. So based on what you answered in the last question, now I would like you to answer where is this person or this group or organization based? What maybe country or like continent? And I know some of you maybe answered like a bunch of different like organizations or like groups, so you can just like pick like one of them to like answer this question. That's fine. Okay, so I see US, Europe, UK, India, internationally based, North America, again Europe, US. Cool. Okay, let's move on to the next one. So let's keep this word cloud in our head, which I would argue is mostly Europe, UK, US, with maybe the exception of India. So, okay. Now let's talk about primarily where is their global surgery work that you know of based. So what maybe countries or what continent is that? Awesome. Uh, am I the only one, or can everyone see that our predominant answers, the like the highlight answer here is Africa, right? And so when you start connecting the dots, and if I ask you what is global surgery, just based on these three questions, I would argue that the definition would be it's surgery done by people from US, UK, Europe in Africa, right? And so that that definition naturally popping up in this conversation is what I think is the troublesome part of global surgery and global health in general, right? Uh, and we'll go on a little bit into this. So let's also talk about how did you know about them or their work? Yeah, Ramita, do you have a question?
Yeah, it's amazing to see because India has the world's biggest population and China has the world's second biggest population, but most of the funding and the work in global surgery goes to Africa and it is mostly African centric. So it is something that we have seen over and over again because global south is not just Africa. So Asia also suffers. For example, India, China may have decent medical infrastructure in some areas, but when it comes to Mongolia, Nepal, Bangladesh, Myanmar, Cambodia, even Sri Lanka, which is my country, like we suffer from much of lack of surgical care in some places. So uh, this is grossly overlooked, so which is a bit surprising and interesting to say the least. So that's a very good point, I think.
Yeah, yeah. I mean, and also, yeah, like you're right, like a lot of global surgery research practice is targeted, yeah, is done in and for uh, African countries. Uh, but again, look at the flow of flow of research and knowledge and practice, right? So it's it's kind of alarming that when I asked where where the group that you know is based, we didn't see a single response in Africa, right? And when we said where are they working, that's when we saw Africa, right? Ideally, you should be able to see Africa in both those responses, right? You should be able to see Asia in both those responses. And so, yeah, like the questioning that I want you to do is, you're right in saying that like the largest populations in the world seem neglected when it comes to global surgery. But I think it's also important to ask that the work that is happening in the other parts of global south, who is truly doing that and benefiting from that, right? Because if I mean, yeah, like one of the things I'll quickly take like a detour, but like one of the things that we also talk about in our like article is that the at least like the view of decolonization that Professor Sharma and I take is that the central philosophy of all of this should be uh, our problems are solutions, right? If it's my problem, the solution needs to start from me. And so I can definitely take help, I can collaborate, I can learn from other people, but other people imposing their solutions on me is not solving my problem, it's still an imposition, right? Yeah, but that's an excellent point, and we'll maybe talk a little bit, especially about we'll especially talk about like China and India, maybe in the Q&A. Okay, so the next question was, how did you know about their work? And I can see that majority people said read in research paper and news. So now let's think about that for a moment. That means that people who are from US, UK, Europe, but work in Africa, publish more research, get covered more in news, and they are sort of the people that get highlighted to us, and especially to young students and the next generation of practitioners, researchers, and leaders, right? So it becomes really challenging to, I mean, yeah, like again, like my anti-colonial colleagues would say that we need to dismantle the structure, and I would agree with them. But my point is that dismantling is like so far out of the sight, it becomes challenging to question the structure if the influences that we have are a certain way, right? So if we read about PGSSC, Lancet Commission, Incision, and all of these are amazing people and amazing groups, by the way. So I want to be clear that I have nothing against a particular person or a particular organization or a particular country for that matter, right? I know that especially in global surgery, it's a small community of people really striving to achieve surgical care for people around the world. My point is that even within that, it becomes difficult to question some of these hierarchies and these things unless we actively have exercises to do them, right? So let's move on to, we have maybe 2 more questions. So let's keep going. So as far as you know, what does this organization or group of people work on? And you can be relatively like brief. Yeah. Okay. So I see training, advocacy, research. So a lot of that, except research, maybe falls in global surgery as movement, provision of surgical care, increasing surgical access. So that would fall in discipline because it's practice, identifying barriers in access. Yeah, so that's amazing. My guess would be that that's connected to research in some way. Education, policy, financing. So I'm glad that education, training, policy, these things are coming up. See more research. Awesome. Okay, so what we are looking at is research, training, policy, and practice or like clinical service, right? Okay, let's keep going. Okay, so based on your last answer, to whom do you think their work impacts the most? And so, yeah, kind of like the options that we have are researchers, academics, policymakers, clinicians, community members, and then, yeah, if it's something else, then others. And I think you should be, for this one, I think I set it to like multiple kind of like choice. So you should be able to like select more than one if you want. Okay, awesome. So again, like predominantly, people say that it's, okay, good to see that we are, the bar for community members is increasing. Okay, but like, so it looks like all the organizations that people are talking about definitely do research. And so based on this, I would argue that their primary audience is other researchers and academics. And so that's again something that we really need to think about, right? If we in global surgery as a discipline are simply working for our colleagues, or even primarily working for our colleagues, I'm not sure that that's a really good impact statement to have for ourselves, right? Uh, Ideally, you would expect that this is at least split among the three groups, or even more ideally, that more people, more organizations and institutions are working on things that would directly impact communities and community members, right? And so one of the reasons, again, why this happens is not because people don't want to work for community, but it's because the institutional setup, the institutional hierarchies that we have genuinely prevent good people from directly working with and for communities. So I can tell you in my work that what ends up happening is that you sort of like start applying for funding that would be reviewed by other global surgery researchers, right? You start publishing, which is you start publishing papers, research articles that would sort of like help you, well, your career, but also that would help the community. But the way you define that community is basically other clinicians and researchers. So it's not really the people or the larger public that you want to work for or that you want to work with, but it's this exclusive and almost elite group of people, right? And so again, that happening repeatedly across the world, across institutions, is a sign that we still haven't dismantled colonial hierarchies to the extent that we should have. Okay, and then the last, I think this is the second last, but yeah, the question that we have is, are they the best institution or group to work on that problem? And if you think so, why is that? And so let me maybe probe that a little bit and say, so for instance, let's say you responded Lancet Commission in, like your initial responses. And so now if you're talking about policy, is Lancet Commission the best group of people to be working on policy in Africa? I mean, you can answer yes, but why is that? Okay, I see a response saying could be improved. Awesome, I see another response saying prospective LMIC representation will be more efficient to address global surgery issues. And I absolutely agree with that. So again, like if you look at all the responses that we gathered across questions, institutions based in US, UK, Europe, working on problems in Africa and finding, let's say, policy or like research solutions who get recognized for their work in published literature, in news articles, but without having any real representation from those places. And so again, that's a real problem, right? Because again, there are like so many layers to it, but at least like the basic ethics of doing research and basic ethics of knowledge sharing is that we need to have equitable credit sharing, right? And so clearly we are sort of like failing to achieve that as well. All right, and the last question, if you were to work on that problem, right, how do you think you would do that differently? And so we'll maybe give like 10 seconds, and it's completely okay if you don't have a response right now. But I certainly want all of you to think about this. And yeah, maybe keep this question in the back of your mind for the rest of this talk, but also maybe the rest of the day and the week. Because an important part of questioning is not just saying what doesn't work, but also thinking what may work instead, right? And I think the poll should be on even as we go along. So you can always like go back and respond. But for in the essence of time, I think I'll keep moving. All right, so let's talk a little bit more about then our second case. So I want to talk about an example of decolonizing the global surgery movement. And I want to talk about decolonizing as doing and not as questioning now, right? And so the example that I want to focus on today is what a lot of rural surgeons in India have been doing for past several decades. So there is a group called Association of Rural Surgeons of India, RC, and there are amazing people within RC who have been doing global surgery even before global surgery was a word, right? And so these are folks who have been providing care in rural and remote parts of India. But not just that, they have been traveling to other Asian and African countries, training people there, learning from them. They have been exchanging clinical notes, procedures, medical devices. So they have been actually sharing resources with other people who could benefit from them. And so I want to focus more specifically on someone who I truly admire. So in the picture here, in both pictures actually, you see Dr. Jnanraj Jasudian. Dr. Jasudian at one point was, I think he was like president or secretary of RC. He has been a huge part of global surgery as a movement even before 2015. Uh, Specifically for Lancet Commission and for 2015, India had its own sort of consensus statement talking about what problems Indian surgeons and especially rural surgeons think are important and should be prioritized. And Dr. Jnanraj was a big part of sort of uh, drafting and advocating for that consensus statement. Uh, we had him as one of the speakers in a meeting focused on data innovation, program implementation, and community action that we did last year in India. And so he talked extensively about the work that he has been doing in the space of surgical innovation, in the space of helping out his patients financially. So literally forming sort of like micro lending communities within villages who can then pool their money for funding surgery of one particular person or kid who needs surgery in that village, right? So truly amazing grassroots work. The image on the left is also him operating and training people in rural hospitals on a device that he and his team built up, which is a laparoscope that lets you do laparoscopy without the need of any gas insufflation. So I would really love if all of you going back, Google him and see what he has been up to. And it's amazing what you can do once you set your mind to really solving problems of people at the grassroots, right? The second thing that I want to talk about as decolonizing the discipline of global surgery is an example that I was really lucky to be part of early on, which was co-developing Key Suite. So Key Suite is again a laparoscopic tool. So like laparoscope and like retractor that lets you do keyhole surgeries in places that do not have good carbon dioxide insufflation, that maybe do not have good supply of electricity, water, a whole bunch of places, right? And so from the surface, this project looks really similar to all other global surgery projects that we think of, right? So this was done, like this was started at a high income surgeon in US at Duke, and then was done in collaboration with people, with hospitals and universities in Uganda. And so again, on the surface, typical colonial global surgery project. But the PI of the project, so who's also pictured here, yeah, so I don't know if you can see my pointer, but Tamara, who is also my mentor, she imbibes the spirit of decolonization. And so even in a project that could have gone in a largely traditional colonial way, she kind of had set up where people would come together, work as equals, and would benefit from that mutually. So just to give like one example of that, the engineering student who were working on developing the laparoscope at Duke did not build the laparoscope in the facilities that the School of Engineering had to offer. We set up a small shop in kind of like one of the outside spaces in the gardens in Duke, and they were supposed to work only with the materials that could be manufactured in and that would be easily available in Uganda. And so the way they worked is that they worked on developing some of the things at Duke in North Carolina in US, and they kind of had another sort of like paired bioengineering buddy in Uganda at Makerere University who was doing the same thing in the same setup, right? And so this gave the students at Duke really good appreciation of what innovation for and in a low-income setting would look like. But this also gave the students at Makerere University an opportunity to be treated as equals and to really contribute to the device that was being built, right? So from the very start, we were cautious that this is not a device that is built in the US and then brought to Uganda. This is a device that is built for people in Uganda, by people in Uganda, with help from people in US, right? And so there are multiple ways in which you can do the same thing. So this is a really good example that when we say that we need to like dismantle colonial systems, no one is really talking about like burning things to ground. What we mean is that we need to change the ways, we need to reflect upon the ways in which we currently do things and change them in a way that it really benefits the people that we are working for, right? So I'll pause there. We can chat more about things, but I thought this was, yeah, like the case studies was maybe a good way of telling you how I think people are doing some amazing work when it comes to decolonizing global surgery. So yeah, thanks so much for listening.
Oh, I'm sorry. Thank you, Dr. Zadey. That was a very enlightening and useful and interesting topic that we, as doctors, as medical healthcare workers, as members of the community, should look into in the days to come. And especially what is like kind of interesting is like you said, like no one is talking about burning things to the ground. Everyone wants to innovate and make things better for everyone involved, especially the disadvantaged and rural communities of the global south. So I wanted to ask some questions from you. These have been mentioned by you in the starting of the presentation also. How does post-colonial influence impact global surgery? And what structural changes are needed to reframe colonial hierarchies in global surgery?
Yeah, I mean, in part, I think Ramita, in part, we kind of like answered that, right? Like there are really small ways in which we can do that. Like, yeah, like the like the colonial influence, even after, yeah, like, yeah, we have like 100 and 90 or like 200, like whatever countries, independent countries now. But yeah, we can still see that everywhere. We can see that in clinical practice, in our textbooks, in research articles, everywhere, right? And so there are really good but small steps in which we can change that. Yeah, my point of like sharing, I mean, in a different way, the reason I wanted to share about the work that Dr. Gyanraj does is because a lot of that work has been going on for such a long time, but I do not see that get highlighted even by people from and in India, right? So even among my colleagues in India and Asia, when people think of global surgery, they think of specific people and that's it. But I would argue that what Dr. Gyanraj is doing is is global surgery. B, it is a decolonial way of doing global surgery, and it's really impacting other clinicians around him, and not just his patients, but patients around the world, right? So there are small ways in which we can sort of like change those structures. One of the ways is actually talking about examples that not a lot of people know about, right? So yeah, I mean, I could have talked about other like groups as well. And again, like I said, to be clear, all the groups are doing amazing work and everyone is trying to push for the larger good. But even within that, there are people and institutions that get highlighted and that get the recognition and others that don't. So I would argue that as a start, that has to change, right? So hopefully in the next like series or in next talks or whatever, I genuinely want that it's not someone like me or it's not me who's being invited to do this, but someone who is actually working at the grassroots, right?
Dr. Preeti had a question. She has raised her hand.
Yeah. Siddesh, that was a wonderful presentation. I think as a surgeon, as a young surgeon, I've learned a lot of depth of global surgery and what it entails in the coming age. So my question is about the changing paradigm shift that is ongoing with telerobotic surgery. So what role could telerobotic surgery or space technologies play in again defining the uh, power and partnerships? Because it again sort of reflects on the same line again, the powerful entities again owning the ground. So how can we break the chain?
Yeah. Okay, that's a brilliant question. And I honestly do not have like a straight answer for that. But I will say that there are a bunch of things to consider there, right? So the first thing would be that a lot of these innovations, ideally, even for the sake of like having better technology, would benefit from constant feedback from the start, from clinicians and people who would use them. So a major problem that I would argue with a lot of like, at least like in my knowledge that I see from like robotic surgery literature, is that this is a setup built for tertiary teaching high-end hospitals in high-income countries, right? And so if we really want to make telesurgery or robotic surgery a global vision, we are going to need alternative versions of that setup that would work for all those different settings, right? Uh, but that will only happen if these technologies are co-developed. It cannot happen if you try to develop them like individually and independently in like your lab or like your global health institute or like whatever, and then try to transport that to another place, right? So I think, yeah, like my answer to sort of like technological innovation in the context of surgery would be that we need to do that in sort of like a development way. And so we need to follow not just like we need to follow that perspective, but then we also need to have guidelines that are designed that way. We need to have checklists that are designed that way, right? So yeah, the other thing is that I I also it also kind of like bugs me sometimes that the way we look at innovation and technology is that there's an inherent and like implicit assumption that it's something that is built in places that are like well off and then used in places that are not well to do. But that's not really true. A lot of innovation, including technological innovation, happens in places that have severe resource constraints. And the reason it happens is because those are the places that need it the most. So I think even in thinking about what we call, like what we consider technological like innovation, I think we also need to expand like that definition to include a whole bunch of things, right? So for instance, even when we talk about telesurgery, we now tend to, especially like post-COVID, we tend to think more about, sort of like having maybe post-op calls on Zoom or like whatever, right? But forms of telesurgery have been done all around Africa and Asia by surgeons who, let's say, live in urban areas, but work with rural healthcare providers and sort of help them out, right? It's just that that vocabulary of what they are doing is telesurgery was not there. So I think it's really important that we start recognizing that, like even when we say technological innovation, co-development is important, and we expand that definition to include the really truly innovative things that people around the world are doing.
Absolutely agree with you on this one. One more question. Carrying forward the essence that the answer gave, would mobile surgical units be the answer to this innovation? I mean, if we cannot do telerobotic surgeries right in the place, so MSU could be something to uh, uh, to bet on, because it ensures connectivity and surgical care at the most remote areas.
MSUs would definitely be an answer. And again, like there are a lot of people thinking about like MSUs, secondary surgical units, walking blood banks. And so like all of these ideas have sort of like the same central premise where you kind of have like a hub and like spokes, and the spokes are mobile and they can reach out to communities, right? So that's a brilliant idea. From decolonial perspective, I would say that that would work if we do a couple of things. One, if we then train, upskill, and reskill the healthcare workers working in those mobile units to be able to provide that kind of care, right? I mean, even within medicine, we don't like to talk about it and we don't like to acknowledge it too much, but we know that there is also a colonial hierarchy within medicine itself, right? Uh, I mean, med students, although would listen to nurses, they don't like listening to nurses. They would rather have the same exact advice given to them by a doctor, right? So mobile units would work if healthcare workers working in those, which in most cases, by the way, in a lot of these places are going to be nurses, technicians, auxiliary nurse midwives, and community health workers. So not a lot of doctors are going to be interested in working in a mobile unit. Okay. Realistically, it's going to be all the people who we like to call allied healthcare workers. So if we upskill them, if we empower them, and if we sort of like get out of our colonial hangar, as like surgeons, clinicians, whatever, then mobile surgery units would work.
I think that's
Amazing.
I think that's a very good point, because most of the healthcare work has exclusively been tied to even something which I have seen back in Asia, South Asia, is being tied to the surgeons and exclusive healthcare were like it's been like a tight fenced society. So it's but you can get a lot of contributions from other sectors. There should be like multicultural collaborations, disciplinary collaborations in global surgery. So for example, right now, with all these innovations and disruptions are happening because there's a collaboration between engineering and non-medical stuff with the medical stuff. If that was never the condition, then we wouldn't enjoy all these privileges which we are enjoying today, technologically speaking. So that's a very good point. That's a very good thing that I have seen in South Asia as well as here in the US. So I hope it gets mitigated in the days to come. And does anyone have any questions, more questions to ask from Dr. Zadey?
I see a question in the chat by Abdul Karim. What does a decolonized global surgery ecosystem look like to you in 10 to 15 years? And what role can networks like Incision Global play in shaping that vision?
Yeah, that's a brilliant question, and I love that someone asked that. Okay, so yeah, I think there's yeah, like I said, there's like a lot that we can change, and there are a lot of like small things that we need to change. To me, and yeah, this is where I would get radical and say that to me, decolonized global surgery ecosystem would be one which is not centered around surgeons in terms of discipline and in terms of movement, right? So and I'll give sort of like an example of each of them. So in terms of discipline, I think one of the drawbacks of global surgery is that, well, even before Lancet Commission, but what we have imagined global surgery to be is sort of like a field where a surgeon would operate in clinic and then would head out and sort of like teach students and then go on ahead in the day and talk to policymakers and then go to their office and do research and then go out and engage with community to tell them why surgery is important. And so we have spent a lot of time as a discipline on equipping surgeons with more and more of non-clinical and non-surgical skills. And that's amazing. I mean, surgeons are exceptionally brilliant people. They are really focused, good at what they do. But to expect that an individual can do all these things is an insane expectation to have, right? A rather better approach would be that instead of asking surgeons to write these long policy articles and then training them to do so, we actually get policymakers interested in working for global surgery rather than asking surgeons to learn one more kind of data analysis. We actually get statisticians, economists, epidemiologists interested in working on global surgery problems, right? So, and the example that I like to give is that some of the most successful sort of like areas in global health have been HIV, right? I mean, HIV, I would argue, is literally at the center of all of global health. Like, yeah, HIV/AIDS has helped us think about everything that we today know in global health, right? But HIV is not just about a bunch of infectious disease doctors. You will see a whole bunch of people from all kinds of technical and non-technical backgrounds working amazingly, efficiently, and proudly on HIV, right? So I think with respect to decolonized surgery ecosystem, in the context of discipline, I would love to see that happen in the next 10 to 15 years, right? Because that's the only way that we can really get surgery to everyone. With respect to the movement, I think one of the spaces where we have lacked, and I mean, when I say we, I include myself in that, where we have lacked is that we still have surgeons and experts like me talking about why global surgery is important. Rather, we should have had patients talking about how having a surgery benefited them, right? How having a surgery for their kid benefited the entire family, right? We should have had patients talking about the kind of post-op safety issues that they face, right? And so, yeah, even when we say that we are advocating for like neglected surgical patients, we don't let patients talk about their problems in this larger movement, right? So there has to be more representation of patients, of caregivers, of family members, uh, even of students for that matter, right? Uh,
If you
yeah,
think it in a way, there is if you I'm also like thinking a bit radically, if you might say, like there's an unfair concentration of power in here when it comes to the shots in global surgery to the surgeons. Sometimes the ulterior, the driving power of the surgeons, certainly surgeons are all excellent individuals who have all the want the best for the society, but sometimes in some scenarios it could be money motivated, it could be politically power motivated, who knows, like different scenarios might occur. So I think in here you might need a more, like you said, a public representation and a representation from other sectors in the allied healthcare sector as well as non-healthcare sectors. So that's a very good point.
yeah. I mean, like one example that you gave, which I love and which I think is really true, is that uh, yeah, I mean, a lot of medicine has been developed not just by doctors, but also by engineers who have been working on all these, yeah, devices that we now use, right? So, yeah, for that to happen, yeah, we need to like decenter global surgery from surgeons and really make it about everyone who wants to contribute to it, right?
Surgical care is universal at the end of the day. So, Dr. Preeti, do you have anything else to add? Any questions to ask? Anyone
Uh,
else? We have,
no,
yeah.
no questions. No questions. I think this is a heavy dose for all of us to, process through. So I request all the members to take your time. You can reach out to the co-chairs or Sadesh. We will drop you his mail address in the chat box. So, Ramita, please, we can give the farewell note, please.
Thank you, Dr. Zadey. Thank you, Dr. Preeti, especially, and thank you everyone from Incision for organizing this. And it is my pleasure to take part in this and to hear this interesting and engaging and quite, I wouldn't say it's a webinar, it's somewhat of a dialogue, I would say, and a discussion more of. So thank you everyone and hope you have a nice day. Thank you, Dr. Zadi. We hope to invite you to future webinars as well because I personally, when I found it very interesting and engaging and
Yeah,
quite
thanks
relevant.
so much. Yeah, thanks so much for inviting me. This was amazing. Yeah. And yeah, I mean, I really want young people, especially young doctors, to think more about how, yeah, how they can be not just good leaders, but good supporters and cheerleaders for other people in health and healthcare, right?
Okay, Dr. Preeti has also shared Dr. Zadi's email address in the chat box. So if you are interested, you can contact Dr. Zadi after the webinar. I will certainly be contacting Dr. Zadi right afterwards. Thank you so much, Dr. Zadi, and everyone have a nice day and take care and see you soon in the third episode of Global Surgery Lecture Series. Thank you.